Hi, everyone. I will speak today about C5 palsy, which is a very interesting topic. I have no disclosure. So what's the definition of C5 palsy? It's de novo aggravating muscle weakness at the level of C5 with or without sensory disturbance after cervical spine surgery. So the C5 palsy is not uncommon, but it is the most disabling postoperative complication and is current around prevalence between 0 to 30% in the literature. The first one who described the C5 palsy was by Keegan in 1965, and he mentioned it as dissociated motor loss due to compression of the nerve root. Since that time, there's multiple theories and multiple studies to study what's the pathophysiology and the mechanism behind the C5 palsy. So there are multiple theories. The first one is direct nerve root injury, either by mechanical, electrical, or thermal trauma during the surgery. Or the other one is nerve root ischemia, reperfusion injury post-decompression, preoperative and subsequent postoperative spinal cord rotation. And the most recent one is post-decompression nerve root tethering or traction injury. Although all those aforementioned theories mentioned all the cause, but none of them proven to be as a cause of the cause for this injury. But there's multiple literature and multiple investigation mentioned and suggest that the nerve root traction or tension may be the leading cause of all of those theories. So there's different manifestation and different presentation for C5 palsy, depending on the etiology, either early or delayed, painful or painless presentation, single or multiple nerve root involvement, minor or severe weakness, and good or poor recovery. And here where the AO came with its study, which is the systematic review, which was published 2 years ago, 2019. And they studied the risk factor. The aim of the study was to study the risk factor for C5 palsy. And they reviewed 122 articles, and they included about 16 articles. And they divided the risk factor into demographic, clinical, surgical, and radiological risk factor. So let's start with the first one, demographic risk factor. There was no association between C5 palsy, sex, smoking, diabetes, body mass index, or other comorbidities. But there was an association with the increased age with the C5 palsy. Clinical risk factor, it was a mixed result of association. So for the OPLL, longer disease duration, preoperative symptoms like Murex scale and GOA score, it shows that there's mixed result. Some of the study will show that there's association and others shows no association. What about surgical risk factor? There was no association with the C5 palsy and number of surgical level or use of allograft or autograft. And here we'll come to the interesting one, the radiological risk factor. There was mixed result of the C5 palsy with the posterior spinal cord shift, change in C2-7 sagittal angle, and lamina opening angle, and preoperative anterior posterior diameter. In the most interesting one is the association between C5 palsy and preoperative spinal preoperative foraminal stenosis, which was a strong association with the foraminal stenosis at the level of C4-5, and preoperative spinal cord rotation, which was mentioned in 2 studies. As you can see here on the diagram, that there is a rotation in the spinal cord on the left bottom picture around 12 degrees. So the most common pathological mechanism for C5 palsy is the tethering of the C5 nerve root. But why C5 by itself? So because it's shorter rootlets, as you can see here on the right side table, that the shortest nerve root of all cervical spine is the C5, and it has more horizontal course, more smallest nerve root in cross-sectional study, and the facet for C4-5 is most anteriorly protruding, and it has also more numerous foraminal ligament, as you can see it here on the picture, that there's intraforaminal, extraforaminal, and transforaminal ligament, which all has to be released when you are doing the surgery. Here's a very interesting study, which was published 20 years ago. They did the experimental study for the nerve root after stretching. And when there was 6% strain, there's 70% decrease in the electrical conduction and slow recovery. And where there is 12% strain of the nerve, there was complete conduction block with minimum recovery. The treatment option for C5 it has only physical therapy. There is no specific treatment. The physical therapy in a matter of cervical traction, muscle strengthening, range of motion, and low frequency wave. The prognosis for postoperative C5 palsy usually is dependent on the severity of motor weakness. Like 71% of the patient with the severe cases, which is muscle power of 2 or less, they will recover to useful level, and 96% of the patient with mild cases were fully recovered. As you can see here on the table, that most of the patients with mild cases, more than 50% or around 50%, they will recover in less than 3 months, and in severe cases, most of them, they will recover after 3 months. So in conclusion, C5 palsy is a common complication following cervical decompression surgery with a pooled prevalence of 6%. Although many risk factors have been previously reported, it's multifactorial in nature. But the most interesting one is that both foraminal stenosis and preoperative spinal cord rotation were found to be associated with C5 palsy. Patients with palsy usually have the good prognosis, but the patient with a severe C5 palsy, they have longer recovery time than mild cases. Thank you.